Welcome to the ATS webinar on new and revised codes for interventional bronchoscopy. Today's call will review the appropriate use of new and revised codes available to the physician community for interventional bronchoscopic procedures. I'm Gary Ewart, and I will be moderating today's call. Our presenters today are Dr. Kevin Kovitz and Mrs. Kim French. Dr. Kovitz is a member of the ATS Clinical Practice Committee and is an expert on billing, coding, and regulatory compliance issues. After several years in private practice, Dr. Kovitz recently joined the faculty at University of Illinois. Dr. Kovitz is a provider of interventional bronchoscopic services. Kim French is a practice manager at the Suburban Lung Associates in Metro Chicago area. Kim has years of experience in effective practice management, including accurate coding and billing for pulmonary medicine. With that introduction, I would like to now turn it over to Dr. Kovitz and Kim.
Thank you, Gary. Thanks for that introduction. On this slide, you see our contact information by email should anybody have questions subsequent to this presentation. Next slide, please. Just to disclose conflicts, I've been an investigator for emphysema trials with valves, most specific to this, the spiration IBV valve trial. And I've been a consultant for Olympus, CareFusion, and Varian through my employer. Mrs. French has no conflicts. Further, the CPT codes are copyrighted by the American Medical Association. Next slide. So we will be going over changes to the CPT codes that are new for 2013, effective January 1st. As many of you know, it's a multi-year process to get these codes through, and due in no small part to the efforts of the ATS and their clinical practice committee, among other groups. We'll talk about some new instructions and some deleted codes. Next slide, please. The next several slides we won't go over in detail just yet. It's in chart form. These charts will be at the end of the presentation. It's more for use for you all as a resource so that you can look these up directly. And we will be talking about, on this slide, bronchial thermoplasty, the two new codes. The first code, the 31660, has to do with the initial treatment of one lobe. We'll talk in more detail about thermoplasty a little later in the presentation. If you do two or more lobes, it's a distinct code, 31661.
For the audience, pointing out this replaces the Category 3 tracking codes for bronchial thermoplasty that were valid up through 12/31 of this year, and they're at the top of the table, 02760 and 77T. They are now Category 1 reimbursable CPT codes.
Okay, thank you. Next slide, please. We will also go through during this presentation the new codes for bronchial valve placement. There's an approval for bronchial valves for the use of air leak in air leak patients, and we'll talk about that in a little more detail. The listing is here, again, replacing tracking codes that are listed at the top of 0250T, 0251T, and 0252T. There is a code for insertion, for balloon occlusion and subsequent insertion of valves, no matter how many valves you put in a distinct lobe. That's 31647. Then there is, at the bottom of the slide, if you put in each additional lobe, 31651, which is an add-on code to that initial 31647. Again, we'll go over in more detail. And then these are designed to be removed, so there's removal for one lobe, the initial lobe, 31648, and then the subsequent lobe as an add-on, 31649. The key in all of this for bronchial valves is to realize that these codes are not in correct numerical sequence, but these are the way they exist. So you have to be careful that 31647 goes with 51 and 48 goes with 59. There have been several publications that have gotten this wrong, and you got to be careful with that. Reflexively, you'd think 4.7 is followed by 4.8 in the same procedure, and it's not.
CPT 2013 is correct. In the professional edition, CPT assistant and some of the code corrects are incorrect. So if there are coders in the audience, be careful that you load your systems with the proper CPT code, even though they are out of sequential order.
Next slide, please. Now, there are several new codes for thoracentesis and chest tube. We'll go over that again a little more later. We're not going to discuss what a thoracentesis or a chest tube is. Basically, these new codes have come up as doing a thoracentesis without image guidance, whether you use a catheter or a needle, doing one with image guidance as a distinct code. So that's 32554 and 32555. Then there's what's called pleural drainage, percutaneous with an indwelling catheter, which is 32556. That's without image guidance. It is a chest tube, but the wording was called catheter, which led to some confusion in how these were developed. But that's if you put it in a catheter in over a wire, for example. And if you use image guidance, then it's 32557. You can see what numbers have been replaced. The RVUs have changed somewhat as well. And if you go to the next slide, please. Chest tube, which many of us would consider putting it over a wire or making an incision and putting your finger in to be similar procedures. Basically, if you do it open, once you've made that incision and put your finger in or something like that, it's considered an open chest tube, and that's 32551. It's revised. It's considered open. It's considered a more invasive procedure. Whether you agree with that or not, this is what the codes have sorted out to. We were asked to revise and revisit these, and this is what resulted. Note that this is distinct from an indwelling tunneled catheter, the Pleurax catheter, or other similar catheters, and that's still 32550. There's no change there. We'll get into a little more detail later.
The previous slide, which, Gary, you don't have to flip back to, but for the audience, you will never, with a thoracentesis nor a chest tube, you will never again bill for ultrasound separately. It's either with guidance or without. It's embedded in the code, and it's priced within the code.
Okay, next slide, please. So this basically gets to that point of what you're not supposed to report with. The open procedure and the parentheticals are listed, and this is for your reference. Imaging is included or not included, and that's all built into the code, and the open procedure does not account for imaging or not. Next slide, please.
A few language changes to existing CPT codes. Under the bronchoscopy section of the CPT, you'll see that 31634 with balloon occlusion with assessment of air leak, administration of occlusive substance, i.e. fibrin glue, if performed. That's fine. That cannot be reported with any of the new bronchial valve insertion codes. And it's important to remember that because in the old days you may have reported with a subsequent 31699 or 31899 unlisted procedure code. That is a change for 2013, and if you had bundled billing set up in your system, you're going to have to change that at this point. 31635, removal of foreign body. Again, do not report that with removal of implanted bronchial valve. It includes that.
Okay. Next slide, please. So we're going to go into a little more detail of all of those things by separating out the procedures. Just briefly for bronchial thermoplasty, this picture was taken off the website of the company, and the website is noted. Basically, it's a picture of a catheter with an expanded end that's used for radiofrequency ablation. It is a heat, a thermal energy delivered of a defined period of time so that it causes damage to the airway smooth muscle. Next slide, please. The typical case is of a patient with chronic persistent asthma who's poorly controlled despite optimal medical management. The procedure is noted uses a radiofrequency ablation or thermal therapy delivered in a controlled manner with a catheter via a bronchoscope. Multiple activations to the visible lobar and segmental airways are done basically every 5 millimeters. The procedure goes through about 50 to 75 activations. It can be a little more or a little less depending on what lobes you're doing, and I'll go into that in a little bit. It can be done under moderate sedation. The procedure itself takes about an hour or so. It can be done deeper. Moderate sedation, if done, is included in the code if you're using an anesthesiologist, and general or a deeper anesthesia, that's billed separately by the anesthesiologist. Next slide. So these are done in 3 sessions, about 3 weeks apart. It's usually an outpatient, as the patient must be stable and not in the middle of an exacerbation. Although it could be done as an inpatient, I'm hard-pressed to imagine that scenario. First, you target one lower lobe, and that's the 31660 code. The subsequent session, you target the other lower lobe, again reported as 31660. And then in the final session, you target both upper lobes, and that's where the code comes in for multiple lobes done. Then that would be 31661. It's written as multiple lobes because I suppose theoretically, if it was proven you could do this as more than 2 lobes at a time and a fewer number of sessions, you could potentially report that. But currently, as it stands, it is 1 session for a lower lobe, another session for a lower lobe, and then a 3rd session for both upper lobes. The middle lobe is not treated. And the complexity of 31661 is a little greater. Airways, getting to the airways is a little more difficult, and since it's multiple lobes, it takes a little longer. Next.
Again, bronchial thermoplasty has significantly, well, coverage has improved over 2012. Certainly, being a Category 1 CPT in 2013 will help for prior authorization. These 4 ICD-9 codes are what's currently approved for bronchial thermoplasty for those carriers that recognize it. So you can see the 4 predominant asthma codes is what you should be looking for to bill for patients who are undergoing the 3 sessions of thermoplasty.
Next slide, please.
APC, so in the hospital outpatient setting, the CPT Category 1 codes, as we've just discussed, are 31660 and 31661. They map directly to the ambulatory payment classification, or APC, to 0415, which is a level 2 endoscopy lower airway procedure. And that has been true for 2012, and it will continue in 2013.
Next slide, please.
The good news is the catheter is expensive, but there is a pass-through status on that currently. You can read on the slide, Medicare has granted a pass-through of C1886 for the catheter. That was effective last January. It likely will continue through 2013 and then be sunset depending on frequency of use. It's really unclear whether 2014 will still have that as a pass-through expense. We'll just have to wait and see.
Just a further comment on this. Although these are Medicare-approved codes and these are Medicare criteria, we have to hope other carriers will respect that, and that's not entirely clear. Most of these patients are not Medicare age, so that will have an impact. Next slide. As commented, it's rarely performed in an inpatient setting. You have the slide to how to map this and the procedure code associated, the 32.27. Next slide. As noted, this is an approved procedure for adults with severe asthma. Despite optimal treatment, population is not typically Medicare. Coverage decisions pending local carrier determinations. You have to be clear on this. It has been easy with some carriers and incredibly difficult with others up until this point. Many have called this investigational or experimental despite the FDA approval, and so some still do not cover it. You have to work with your local carriers and see what the issue is. Pending decision is what carriers will do now that there's a new Category 1 code. We just have to wait and see. Just don't assume coverage. You have to pre-certify this stuff.
Anecdotally, on the patients that we have prior authed, it has been on a case-by-case basis. So even within the same carrier, from one patient to the next, it's been a case-by-case medical review.
Next slide. Thankfully, the American Thoracic Society has taken a stand and with a letter approved up through the process and submitted by Dr. Kraft, the president of ATS. You can see the quote there. It's on the website. It can be used for specific carriers if need be. But it addresses the issue of carriers calling this experimental, with the quote, declaring bronchial thermoplasty as experimental is inconsistent with existing literature, not in the best interest of patients, and ultimately not in the best financial interest of, and a blank for whatever carrier. The literature clearly demonstrates the clinical effectiveness on bronchial thermoplasty should no longer be considered experimental. Other organizations are probably going to follow suit, but you can find this on the ATS website. Next slide. So we'll talk briefly about valves. And again, at the end of the presentation, we'll have all those charts we showed earlier so we can talk and answer questions about specific codes. So the endobronchial valve, I took this from the Spiration website. Spiration has been acquired by Olympus. Spiration is one of the companies that was experimenting with endobronchial valves for emphysema, and this particular company took it further as a use for air leak. As you can see in the picture, it's an umbrella-looking device. It is deployed in the airway where essentially the handle of the umbrella faces proximally, so it faces up the airway, where the little feet face distally. It's deployed through a catheter and springs into position. It's done bronchoscopically. And once it is positioned and sits snugly in the airway, it allows secretions and air to come out of a lobe but not get back in, with the idea being it is minimizing airflow across an airway to an air leak, allowing the hole or the fistula to close. Next slide. So you need to pay attention to the fact that I took this off the Spiration website, but you can also find this via the FDA. This is a humanitarian device. It is approved via the FDA as a humanitarian device exemption. It's not a compassionate use. That's a different category. It's a humanitarian device exemption. It's not fully approved for use willy-nilly on everybody for everything, but it's approved, and I'll explain humanitarian device exemption a little more shortly. Authorized use and control prolonged air leaks or significant air leaks that are likely to become prolonged following lobectomy, segmentectomy, or lung volume reduction surgery. The effectiveness of this device for this use has not been demonstrated. That's part of the humanitarian device exemption. Next slide. So it's, what an exemption is, or an HDE, is a special FDA-approved category, different from compassionate use. You need to demonstrate, in order to get this exemption by any company for a device, They need to demonstrate possible benefit and no significant harm. It's rarely done, so full controlled studies are not done. It's expected that fewer than 4,000 cases per year will be done, and you need a local IRB approval and tracking. And the informed consent must be obtained, including the fact that the efficacy is not proven. Next slide. The typical case is a patient with persistent air leak post-lung resection surgery. The air leak has lasted about a week. It can be a little less if it's severe, a little more sometimes, and often until we get the call, it's been longer than that. There are patients that are sometimes done where it's not a post-surgical and they have air leak for other reasons, but the indication, the approved indication is for resectional surgeries that have persistent air leak. Procedure is done via bronchoscopy to identify the leaking airway or the airway leading to the leak. The patient has a chest tube in place, so you can see the leak coming through the chest tube. Typically, this is done with an intubated patient, and these are inpatients. Most commonly, I guess there could be a scenario where they're coming in as an outpatient. They've had a chronic drainage system, but typically they're inpatient. Typically they're intubated for the procedure because the positive pressure helps you identify both the leak and whether any interventions can obstruct the leak. You use a balloon going from segment to segment in an initial lobe and sometimes then in a subsequent lobe with the idea of identifying the most distal airway that will fit a valve, and they come in different sizes. The most distal airway that will fit a valve that will take care of the occlusion you need. Often more than one valve is placed. This lecture is not to give you the exact details on how to do the procedure, but just to realize that there is a targeted lobe, which is the initial targeted lobe treated no matter how many valves you put in that lobe, and that's the code of 31647. And occasionally you'll target a secondary lobe, and this is where you got to pay attention to the numbers. That's a 31651. Next slide. Now, also, as part of the approval, these are planned for removal, where you will find patients for clinical reasons where the valves remain. They're typically planned after a period of healing and closure of the leak for removal at about 6 weeks. It can be a little earlier, a little later, but that's the typical is targeted by about 6 weeks. Although they may be removed for infection and other things, they're actually designed to be removed, and the typical patient would have it removed at about the 6-week mark. It's retrieved with a flexible scope and forceps via an established airway. Again, probably best intubated to be able to do this. Maybe inpatient or outpatient, they could be coming in for the procedure. One lobe, if only one lobe is done, again, no matter how many valves removed, it's 31648. And if you have to do the additional lobe, this time it is in numerical order, and if you do an additional lobe, or for each additional lobe, it's 31649, which is an add-on code to the 48. You can't report them in 49 separately. Next slide. Well, I guess we'll go right on to SBRT planning, and then we'll discuss if there are specific questions about the thermoplasty. So SBRT is a stereotactic body radiotherapy. It's the generic term. You've seen many brand names out there, CyberKnife, for example, and others. But every company has some sort of computer-guided radiation. The bottom line is you're finding a specific target. It's relatively small and isolated. You're trying to, with some form of guidance, so you hit the tumor and not surrounding structures. You hit the tumor with the most intense radiation you desired, and you do it in 5 or fewer sessions. So rather than the classic radiation where it was done over 4, 5, 6, 7 weeks every day, you're doing a much more intense targeted beam, and you're gating it in some way, so you're targeting the moving lesion. In this case, you have a picture taken from the web, from Google Images, from Varian, but again, any company do. And you have at the center the gross tumor volume, and then you have other circles that are sort of the planned targeted volume, so you're allowing for motion, and then the radiating circles, no pun intended there, but the other circles are showing how the doses fall off and avoid other structures. The code for this is 32701, and we'll discuss it a little more subsequently. Next slide.
Key to point out here is the CPT code 32701 is purely for the planning, not to be confused with the actual procedure of the radiotherapy.
Right. And this slide provided by one of my colleagues, Dr. Andy Sue, shows on the left what a typical thoracic radiation would be, where the beam is shot front to back or back to front, but you're getting that whole stretch of lung. It looks like you're getting front to back. You're not targeting. You're damaging a lot of other lung, whereas on the right side of the image, it's more defined target. So you're aiming with guidance to that central target and avoiding or minimizing exposure to the surrounding structures. Next slide. Now, a typical case is a patient with an isolated pulmonary nodule. Perhaps more than one nodule is not a candidate for resection. Sometimes they're not candidates because of their underlying function. Sometimes they're not candidates because they don't want that approach. But either way, you're targeting radiation in 5 or fewer sessions at a high dose. Planning is done to achieve the best dosing of radiation to the lesion while avoiding other structures, thereby maximizing treatment and minimizing side effects. You account for motion in planning and treatment. And this new code is analogous to codes available for neurosurgeons for planning targeted cranial radiation. It's filling in a gap of planning. There wasn't a specific code for the non-radiation oncologist to plan or assist in planning or targeting radiotherapy. Not compete with the radiation oncologist. It's designed to be used in conjunction with the radiation oncologist. It does not take away from what they're doing. It simply leverages the experience of the surgeon or the pulmonologist in terms of what other structures may be local and minimizing side effects if possible. Next slide. So this applies once, the 32701 applies once to the entire course of treatment. You're not replanning through the way and billing again. You may replan or discuss it further, but you're not going to be able to code it more than once or bill for it. The thoracic targets are delineated, borders, volume in relation to structures, and fiducial markers when available. They may have been placed before. They're usually gold markers that allow tracking. If the system requires that, we're tracking respiratory motion. The idea being you want the radiation hitting the lesion but not hitting surrounding lung, and you're accounting for that. It's a collaboration, competition. It's separate from planning, dosimetry, and management by the radiation oncologist. It's distinct from fiducial marker placement. It's the planner coding 32701 not only has to plan it and demonstrate the planning and generate a report, but has to be available to identify and validate the target prior to treatment in a tracking system that does not use fiducials. So you need to use a planning software to generate a report. You need to familiarize yourself with the local systems.
Although not on the slide and not part of this because it is an existing code, fiducial marker placement is 31626 for anyone who may not be familiar with that.
Okay. Next slide. So bronchography has been deleted. The list of codes are there. Basically, Although you may find some people, this is almost never done because CT has replaced the imaging that was gotten via bronchography. CT is more than adequate as a substitute.
I think the Medicare frequency was less than, there were less than 50 done within the last couple of years. And that could have been attributed to coding errors as opposed to folks actually doing it.
I personally haven't done one in 15 years, so it's not that I would necessarily do thousands of them, but it's rarely done. Next slide. And to point out that a key reference that covers a lot of this just came out is the Coding and Billing Quarterly that ATS puts out. It should be readily accessible. It's edited by Alan Plummer, who's also the ATS RUC advisor to the AMA. And we want to also give our thanks to Gary, who's coordinating this whole thing, and to Diane Creer-Morrow, an advisor to ATS on coding. Next slide. So we'll throw this open to questions. The subsequent slides beyond this are the charts we showed earlier, so we can readily flip back and forth between the thermoplasty, the thoracentesis, the chest tubes, the SBRT planning, and the like.
So the session is now open for questions. There are two ways the participants can ask questions. On your screen there should be an icon that looks like an upraised hand. Click on that, and you can either type in your question, and I as the moderator will read your question, or you can type in there unmute, and I can individually unmute your line, allowing you to ask a question. We already have one or two questions. This is regarding bronchiothermoplasty. So the first question is, can pre- and post-procedure spirometry be billed when performed on the day of a bronchiothermoplasty?
Yes.
Yes, the answer is yes. Bronchiothermoplasty is a standalone 0-day global code. You may use spirometry, and if it's medically necessary, you may use an E&M code with a 25 modifier that may or may not be edited out based on your local carrier policy.
A second question, also regarding bronchiothermoplasty. The presenters mentioned Medicare and some private insurance coverage. Any experience with bronchiothermoplasty and Medicaid coverage?
Personally, we actually have not tried to submit to Illinois Medicaid. I don't know what their response will be. We actually have a patient who is going through the evaluation process currently. So unfortunately, I don't have personal experience.
My understanding, it's been a challenge. But beyond that, you just have to work with your local carrier on that. Maybe a state-by-state and region-to-region decision.
Our next question is from Shannon Mitchell. Shannon Mitchell, your line is now unmuted, and you may ask your question.
I'm sorry, that was an error. I think that was my last question was with regards to Medicaid coverage, so I should have lowered my hand. Sorry.
All right. The next question is from Khalil Al-Nasir. Your line is now unmuted, and you may ask your question.
The question was already answered. This was about bronchiothermoplasty also.
All right. Moving on to our next question, Karen Schultz. Up. Has your question also been answered, Karen? All right. The next question comes from Otis Rickman. Your line is unmuted. Go ahead. Otis Rickman, do you still have a question? All right. question, just got an email question regarding the bronchial valve codes, asking if you could again review what the correct descriptors are for the series of bronchial valve codes.
Sure. Gary, if you would flip to the next slide, or the end slide, and you can have that right there, stop there. This is the correct numerical, sequential, or unsequential order of bronchial valve insertion and removal. So these are the long descriptors. This is what's published in CPT Professional Edition 2013. So 4.7 is insertion initial lobe. 5.1, you have to skip down to 5.1, is your add-on insertion additional lobe. And then you back up to 4.8 for removal initial lobe, and 4.9 would be removal each additional lobe. So depending on what reference you use in your practice, be cognizant it may be different from what you're seeing on the screen. The screen is correct, and CPT 2013 Professional Edition is correct.
Okay. The line is now open for additional questions. Are there any further questions for our presenters, Dr. Kovitz and Kim French, today?
Keep in mind until if there's a question that comes in, Gary, just give us a heads up. Did people catch thoracentesis? So you see it's two completely different codes. Be careful about that as you're going into 2013. Not only is imaging included or discluded, the codes have completely changed, and you do need to replace those. Same thing with chest tubes. They're completely different codes.
Our next question comes from Brian Armentrout. Dr. Armentrout, your line is unmuted, and you may ask your question.
Actually, my question is pretty simple. I was just wondering, is it possible to get a copy of this presentation sent via email to us?
This presentation is being recorded and will be housed on the ATS website in a few days.
Great, thank you.
My pleasure. Are there any further questions for our presenters today? If there are no further, next question, Otis Rickman, do you have a question for us? Your line is unmuted.
Yes, can a E&M return visit be billed on the same day as the thermoplasty?
It has a 0-day global, and there is currently no CCI edit on the bronchial thermoplasty codes. So technically, yes, it may be billed. You would need to append a 25 modifier onto your E&M, appropriate level of service. Clinically, maybe Dr. Kovitz can answer that.
Clinically, you may need to. It really depends on the patient. Our practice has been to evaluate the patient within a few days of doing the treatment. We reassess that morning, but we have not been billing a separate E&M on the day of the procedure, but I don't see why you couldn't. I also, I guess, wouldn't be surprised if it was denied, but technically you can do it.
Typically, for our situation, you see the patient interimly in between that 3-week gap of procedure. So if you say you monitor them intermittently, and then you use another E&M on the same day as the procedure, that could be a lot of E&M billing within a 6 to 9 week period. That you may get a denial on that, requesting medical records or additional support for medical necessity. I don't know how your carrier, I don't know what region you're in, but I don't know how your carrier would respond. Ours would probably request additional documentation.
So Dr. Armentrout, your hand is still raised. Do you have an additional question?
No, I don't. Sorry about that. I'm not a physician.
All right. Dr. Rickman, your hand is also still raised. Do you have an additional question?
No.
All right. Are there any further questions for our presenters today? If there are no further questions, I'd like to thank Dr. Kovitz and Kim French for their presentations today. I appreciate the information you shared with us. I'd also like to thank the participants in today's call. And as a reminder, this call has been recorded. Audio and video component will be hosted on the ATS website in the very near future. I'd also like to remind participants that next week at 3 o'clock Eastern, there will be another billing and coding webinar dealing with new codes addressing polysomnography for the pediatric population and forced exhaled nitric oxide monitoring, as well as pulmonary function codes. So I'd encourage you, if you're interested, to join that call next week. And with that, I would like to thank again our participants and our presenters for today's call. And the call will be ending now.